Today we'll be looking at basically an endless search for etiology. It does actually come to an end, but I thought it was a little less poetry than an almost endless search. This is a search that proves fruitless for the etiology. So go through the process of steps where one fails, you move on to the next, that fails, you move on to the next, which is, I think, more instructive than finding the first one, the right one, straight off the bat. It gives you less information for learning, and also in your clinic, you actually get less information than if you have to go through more steps than the simple first off step. It's a better learning process. So here we go. Okay, so we're going to look at medial heel pain. This is pain under the fat pad, not anterior to it, not distal, but under the heel pad, and it's on the medial side, or at the heel pad area. And it's on the medial side. So what's going to come up is fasciopathy, fasciitis or fasciosis, because there's an availability bias here that most therapists seem to use, including people who have been instructed not to say that when the pain's further back. But this is a bias, and you have to correct it rather than not do it, certainly not initially. So it's an availability bias, and it's because this is what your trainings emphasise for heel pain. Plantar fasciopathy, or more accurately, what's been emphasised is plantar fasciitis, whereas it's usually fasciosis. So we can do differential diagnoses, and then we can work to disprove them. Or the other way of doing this is to look at script focus hypothetic inference using hypotheses 1 through n. And then proving or disproving each hypothesis as we come to it. Now, if we look at this first, this is one way of doing it. What I suggest you really don't try and do is try to prove each one of these differential diagnoses. Rather, use a negative differential diagnosis and try to disprove it. One test will often do it for you. You can just scrap that and move on to the next one, rather than like see if not it is that. It's quicker, it's easier, and it's probably more certain. So let's have a look. We've got fat pad atrophy, fat pad inflammation, which we group together and say fat pad syndrome. Subcutaneous bursitis. I've included fasciopathy just because you will, a lot of you will anyway, and then a stress fracture. All of these can give you pain to the heel pad except for the fasciopathy. You can get heel pad atrophy from plantar fasciosis because of the abnormal gait that you're going through and the wearing down of the fat pad, but it's caused by the fasciopathy. The pain in the heel is not the fasciopathy, but the fat pad atrophy. We're not going there. So if we look at each one of these in turn, 1 through 5, we can do a disproving test. 1 through 4 are all proven or disproven by palpation. We can go into the area, palpate through it, and do layer palpation. So we can see if we can palpate the for fat pad atrophy, see if we can palpate the calcaneum and feel that, so it's tender, and it is what the patient complains of. Fat pad inflammation, you go a little less deep, and you can't reach a calcaneum, and the pad itself is painful. And then you can actually do a fat pad squeeze test from each side and squeeze towards the middle, and that may reproduce the pain. And for bursitis, it's really quite a very superficial palpation. It's almost a rolling of your thumb through the skin. Fasciopathy, obviously, you palpate more anterior than the heel. So stress fracture, you do that, you test that one with the calcaneal squeeze test. If that's negative, it's probably not stress fracture. Okay, the other way of doing this is, which is we're going to work on, is script focus hypothetic induction. Now we have for fat pad syndrome, which will be our first hypothesis, we know what's positive with this. It's pain when you step on it. You're better off with shoes and not wearing shoes. If it's atrophy, the fat pad is absent. You can press into the calcaneum and that's tender. If it's inflamed, then pushing on the fat pad is tender, and as I say, the transverse squeeze test of the fat pad may be positive. The other thing is, if this is very inflamed, you're going to get aching after the sharper pains of stepping onto it. So that's our essential illness strips, and what we find when we do the palpation, and that's the first test we do. I don't take any history. The patient walks in and they say, I've got pain in my heel. We just get a foot and just prod it and see what it feels like. And then you can ask all your questions you want to, but that's your defining test, that. And it will differentiate 1 through 3 here. So that in what we've got here is the calcaneal fat pad is palpable, the calcaneus is palpable and tender, and that is saying that H1 fat pad atrophy is increased. This is now your diagnosis is that much stronger. So we come up and we look at the differentials for this. Now this is also bias and error correction. The differential diagnosis is about not just comparing the diagnosis, but also about correcting biases. So they serve the same purpose. So our differential diagnosis will be fat pad inflammation. We can check that by the fat pad squeeze test. Bursitis, very general, very light palpation, and stress fracture is a calcaneal squeeze test. And we can say that all of those tests are negative. So our provisional diagnosis, our working diagnosis, will be fat pad atrophy in this case. Now, let's say that the calcaneal wasn't painful and tender, and there is no tenderness in the heel. So we look to H2, which could be a stress fracture. So up we come again, and we find now that the calcaneal squeeze test is positive, and there's our diagnosis now. Now, if you look, there is no other differential diagnosis here because we've looked at them all here and here. So there's not another differential. You seem to be fairly sure of this. It's sure enough for you to say, okay, I don't know what it is, but it's probably a fracture. Let's get it imaged. So from the rest of this, we're going to talk about this fat pad atrophy, and we'll look at the etiology. Now, if you look above here, I've made each of these columns hypothesis, the hypothesis you come up with, the test and the result of the test of the hypothesis, that's this, and then the diagnosis, that is your treatment, your working diagnosis here. Now that diagnosis may have to be changed if your treatment doesn't work or it doesn't work as expected. And sometimes that means it doesn't work at all if that's your diagnosis, that it's not amenable to our treatment. But when the treatment works as you expect it to work, then you can say, okay, that's our diagnosis. Now it may not be correct. You may just accidentally bumped into the right treatment for whatever that pathology is. But as far as you're concerned, it's the best thing you can say is this now is the diagnosis. Are you missing my pretty face yet? Well, you're going to miss it on this one, but you'll get it on the last slide. Okay, just a thing about the colours. We're starting with a diagnosis of fat pad atrophy. We made it in the previous slide, and now we're looking at the etiology process. So what we've got here, these are the hypotheses of the change in etiologies. The etiology is a pathology, same as the primary diagnosis is. So it's reasonable to have hypotheses for each one of these. So these are etiological hypotheses rather than diagnostic hypotheses. And I could have written that down as EH1, but I didn't. So just remember that these are all etiology. So here we go. We know what the problem is: medial fat pad atrophy. Now, what would happen? Why would that be? Generally speaking, it's because of increased pressure on the fat pad on that side. So, if we look at this, these are the local causes of it, and these are going to exert the most pressure. So we're going to look at the ankle to see if the talus is subluxed, and we're also going to look at the calcaneus to see if that is subluxed. Into eversion, this is where we're really interested, because if it's gone into inversion, the heel will now immediately rotate, and that will bring that medial border down as it everts out. So it does that. And what we find is we have our second diagnosis now, of subtalar eversion subluxation. That's what we found when we looked at this. So this is our etiology of diagnosis 2. That's what we're looking for. So H1 we're going to go the mechanical route and say this is mechanical, and we're going to say it's because of a long leg. So we assess for causes of long leg. Now you can walk them. The problem with walking them is this makes a huge flowchart. For example, I could have a long leg here, but it shows up as a normal gait because there's just enough compensation or overcompensation to occur to equalize the leg length, or there is so much overcompensating occurring that it actually shortens that leg. So I'm going to go around that, and it's not a bad idea in your clinic neither. Look for the causes of a long leg. Now you already looked here, because you looked at the talocrural subluxations and didn't find one. So the only other cause you're really interested in is at the hip. This is the other major cause of a long leg. And this will cause overcompensation through that. And one of the overcompensations can be at the subtalar joint. So if we found it, we found why we're overcompensating there, and we can look for other overcompensations as well to see if anything else is breaking down. If we didn't find a cause for the long leg, then what we may actually have is a short leg. Now we know that the short leg is likely to be there because of the evergent subluxation. But as we've got no causes for the long leg, that is not a compensation for a long leg because we couldn't find any causes for it. So our H2 now is that the leg was actually short. So it could either be a long leg overcompensating, which seems unlikely given that we don't have any other causes, or it could actually be a short leg. So we will basically look for causes of a short leg and can't find it. There, if we do find it, then we've got problems because now we've got to try to figure out how a short leg is going to result in an evergent subluxation of the calcaneus, and it doesn't make a lot of sense. So the leg length may have nothing to do with it at all. So this is the same as not finding anything for us. So what could be happening is a contralateral leg may be short, and this will actually make the other side, the symptomatic leg, be relatively longer, and it's possible that even though these forces are reduced, that could be enough to evert the calcaneus, particularly if the person is over-exerting, overrunning, overstressing things. So we're going to assess the contralateral leg for shortness and the cause of shortness. If we found it, we're going to hold that as a thought. All right, so we've got a short leg on the other side, so we've got a relatively long leg on this side, and we consider the symptomatic leg as a relatively long leg for the moment, not too seriously, because unless they're really heavy on this leg, it's unlikely to be the only cause of this. So we're going to assume that we didn't find it. Even if we found it, you just put it in your back pocket and keep thinking, but keep progressing as if you didn't find it. And what you can say now, it doesn't seem to be mechanical. It's not related to the leg length difference. It's not really related to any forces being generated at the foot. So what else have we got? Neurophysiological. So we come up with H4, which is neurological or neurophysiological. So the one to look for is the major supporters of the artery, the intrinsics and the tibialis anterior posterior. So it's L4 or it's S1. Now we're going to concentrate on L4 and we're going to look at weakness of the tibialis anterior and posterior. And I'm going to hold off on S1 for the moment because if the whole foot collapses, then likelihood is that you're going to get more uniform atrophy of the heel pad rather than one area. So, and also you've still got to explain the everted subluxation on the short leg. So we're going to, when we looked at the tibialis anterior posterior, we found they weren't weak, so it's neither segmental facilitation nor is it a radiculopathy. So the next possibility is that there is a structural problem at the ligament, the medial collateral ligaments of the talocalcaneal joint, and they are weak, and this is basically allowing the foot to collapse. Even though there may not be any forces on it, just a running force, because those ligaments have gone, may cause the heel to evert. This is particularly true because there isn't a muscle that will keep the heel inverted except for the Achilles muscle, and it doesn't do a great job of it. So we could be looking at slow flow structural loss, and if that's the case, then this is occurring through the lateral plantar nerve, because this is the nerve that actually does supply the talocalcaneal joint. So we can assess for fast axoplasmic flow to say yes or no about AX, slow flow AXT loss. What you assess there is the muscles being innervated by the lateral plantar nerve, which is adductor hallucis, or any lumbrical except the first, and they're supplied by the medial plantar nerve, which is a different nerve and does not really supply the subtalar joint. If it's not found, now you can turn around and say, this might be a primary subluxation of the calcaneal, which is another way of saying, I have no idea what's going on, because we couldn't find any etiology. And then you can start rationalizing it and blaming the patient for it. They're doing too much running, their technique's no good, oh, their shoes are bad. But you put the onus back on them, and you basically what you're saying is stuffing some orthotics will get you the heel cushioned, we'll manipulate the subtalar joint, get it moving again, and that's about the best we can do. If you found here that you actually did have a short leg on the other side, then what you may be looking at is a relatively long leg and the amount of exercise they're doing as the cause of the eversion of the calcaneus, and then you can start thinking about equalizing the leg lengths and looking at why that leg is short and trying to deal with that. So this is a very complicated case. There's a lot of no, we haven't got it, yes, we have got it, no, we don't, and so on. So it takes a bit of watching. So I will look at this algorithm a few times and see if it makes sense to you. I completely understand that this is a upper quadrant module, but I think we're past that now. What we're looking at is clinical reasoning in the solution of complex problems, as well as simple problems. So I'm not too worried about doing lower quadrant when you're in an upper quadrant module. The same principles you've applied here in the hill can be applied anywhere in the upper quadrant as well. The thing is to do the process is in stage. Don't jump ahead. Don't look at the detail. Look at the big stuff first. You've got three things you have to concern yourself with: mechanical causes, neurological causes, neurophysiological causes, and that's pretty much it. So go through each one. If you're looking at mechanical, look at mechanical. If you're looking at neurological, stay with neurological, and so on. But you go through each stage, exhaust it, and move on to the next one. And it's time consuming, but this takes time. It's not tedious because you have to think about what you do all the time. I don't find this tedious at all. This is the most interesting part of manual therapy as far as I'm concerned. Techniques are simple, even diagnosis is usually very simple, but this stuff can get complicated, and this is what makes it interesting. Take the time, learn to enjoy it, and master it, and you've got plenty of time to do so. Alright guys, talk to you in a bit. Bye.